Welcome to part 2 of the image analysis for the lateral ankle projection. Image analysis guidelines for the lateral ankle projection state that the lower leg and foot should be demonstrated at that 90-degree angle. So ensure that your patient's foot is dorsiflex. The proximal talar domes are aligned. Okay, that tibio-talar joint space should be demonstrated as open. The distal fibula should be demonstrated about a 1/4 inch distal to the distal aspect of the medial tibia. In an average medial arch, you're going to see 1/2 of the cuboid demonstrated posteriorly to the navicular bone. Okay. The talar dome should be aligned anteriorly and posteriorly. The anterior aspect of the distal fibula is aligned with the mid-tibia. The posterior half of the distal tibia should superimpose the fibula. The tibio-talar joint should be demonstrated at the center of the exposure field. The talus, 1 inch of the 5th metatarsal base, surrounding ankle soft tissue, and the distal 1/4 of the fibula and tibia are included within the exposure field. The images I have here for you is just to demonstrate that proper knee and lower leg positioning for the lateral ankle. Also, the positioning of the lateral foot surface. You want to ensure that that lateral foot surface is parallel with that IR to get a good lateral ankle projection. In the event that the patient cannot dorsiflex, and I mean cannot in the fact that cognitively or physically disabled individuals, this tip here is for those type of patients. To obtain that lateral projection on a patient who can't dorsiflex, the knee can be slightly flexed and immobilized to at immobilized at a point of elevation so that the plantar surface of the heel is parallel or I'm sorry, perpendicular with the IR. That lateral foot surface, you can bring it parallel with the IR in that position. However, if the patient is just stating they cannot dorsiflex, please, I highly encourage you to help support them and comfort them so that you can really obtain the appropriate imaging. In a lateral projection, we talked about in the calcaneus how to determine whether or not we have some lower leg elevation and where that elevation is. In this projection, you first want to look at the tibio-talar joint space, and it is obscured, okay? I would then look at the talar domes. One is proximal to the other. In this projection, I can see that the medial talar dome is sitting inferior to the lateral talar dome. Our lateral talar dome is superior. This should indicate to you that the proximal lower leg, which is the knee, is higher than the ankle. Also, you can look at the fibula's relationship with the ankle, okay? The distal fibula is demonstrated less than a 1/4 inch distally to, or is proximal to the distal tibia. And that talocalcaneal and tibio-talar joint spaces will be demonstrated as closed. So in order to correct this imaging, we got to lower that knee down so that we can get those talar domes superimposed. Now, when the ankle is elevated higher than the proximal leg, you will start to see the lateral talar dome be demonstrated inferior. It's very distorted here, so you can't really see it, to the medial talar dome. More than 1/2 of that cuboid here is demonstrated posterior to that navicular bone. The distal fibula will be demonstrated greater than 1/4 inch distally to the distal medial tibia. It becomes elongated. There'll be also an open talocalcaneal joint space, and the again resultant image for this lateral ankle, that tibio-talar joint space is closed. So in order to correct this, we need to lower that distal leg so that it is parallel with the IR. Get that foot surface parallel with the IR, and make sure you dorsiflex. So let's take a look at rotation. Again, we're going to look for a joint space being open. In this case, there is a joint space demonstrated, but now we need to look at these talar domes. Are they actually superimposed? And in this lateral projection, they are not. So the first thing we're going to look at is, are these talar domes one on top of each other, or is one in front of each other? And in this case, one is in front of each other. The medial talar dome here is anterior, my lines are getting pretty bad here, to the lateral talar dome. That should indicate to you that there is some external rotation. That anterior distal fibula begins to move posteriorly. When you have external rotation, that means that the forefoot is down and the ankle is up. So that moves that fibula posterior to the tibia, and as that medial talar dome brings it anterior. And just the opposite, again, you want to look at these talar domes, and in this projection, the medial or lateral talar dome is anterior, and the medial talar dome is posterior. And in this projection, the heel is down and the toes are up. So an internal rotation, that distal fibula will be aligned anteriorly to that mid tibia. Look at your relationships of your talar domes to determine rotation or determine whether there is some elevation. Once you determine that, you must look to see where the position of that fibula is to determine rotation in a lateral ankle. Let's take a look at this practice analysis. The first thing I want to look for on this projection is, do I have all my anatomic structures? And I do, okay? However, there's a lot of distortion here because we're trying to get a lateral ankle projection, and my joint space is closed. I can't see anything here. So this is an automatic repeat, okay? We got to correct this. When we don't see a joint space, it usually means that there is some type of elevation. And in this instance, the lateral talar dome is proximal to the medial talar dome. Again, there's a lot of distortion, but the other key indicator here is looking at the fibula relationship, and if the fibula starts to kind of move a little bit more proximally than it usually does up here on a good lateral projection, you should be able to determine that the proximal lower leg or that knee was elevated higher than it should be. So we need to bring that leg down, obviously, to correct this imaging. Also, the lateral talar dome here is being projected anterior. Again, there's a lot of distortion here, so I can't really point out the medial as much. Some reason I feel like it's here somewhere. And that means that the heel was down, okay? So we need to get that lateral surface of that foot parallel with the IR. So we need to internally rotate that leg to get that foot projection and that foot position appropriately. Also, if you take a look here, we've got this foot in plantar flexion. So I'm not sure what this technologist did here, but they failed at all positioning guidelines. Again, we're going to take a look at this practice analysis. We need to determine whether or not we can see a ankle joint. And in this projection, I do see a space here. So if there's no distortion at that ankle joint, should determine that there is a little bit of rotation. With looking at this projection, I can tell that my talar domes are sitting one, oops, I drew that little bad there, anterior to the other. The medial talar dome in this instance is positioned anterior to the lateral. Also, you want to look at that tib-fib relationship. If that fibula starts going posterior to the tibia, that should indicate to you have some rotation and that we need to depress the heel because the foot was internally rotated until that lateral foot surface is parallel with the IR. We also need to dorsiflex, increase dorsiflexion so that we can get a true lateral projection with the tibio-talar joint space open. In this last image analysis, again, you want to look at the joint space. Is it open? Do you have all your anatomic structures? We have all our anatomic structures, but the joint space is identifiable. So therefore, do we have any elevation issues? No, probably not. But our talar domes are not superimposed. You can see one is anterior to the other here. And so in this projection, the lateral talar dome is positioned anterior to the medial talar dome. Also, you can see that the fibula is anterior to the mid portion of that tibia. So therefore, the leg is internally rotated. In order to correct this, we need to depress that heel until that lateral foot surface is parallel with the IR, and you want to make sure you dorsiflex in order to get that true lateral projection. This concludes our lateral image analysis guidelines on the ankle. If there are any questions, please feel free to reach out to me at clinic or email me.